I'm pleased to bring on Abe Sutton. Abe's in charge of CMMI. He's the director there, and Abe has a lot of issues to cover. We have a good, healthy chunk of time for him to do it. Abe, what I'm going to ask you to do just off the bat is just sort of reintroduce yourself to all the people here, and then kicking it off after your self intro to high level stuff. From where you sit, where do you see the program going at CMMI? What do you want to achieve? Kind of the big picture. And then I hope you'll drill down with us on a set of key issues. Abe?
Uh, Thanks so much, Cliff. It's a pleasure to be joining you in this group for today's conversation. I'm really excited about it, both because of the impressive group of folks gathered today, but also because of the core issues that we are confronting today that really you have placed on the agenda for today's conversation. And I do think it is a timely one to the point that you just made, Cliff. So, by way of background, I'm Abe Sutton, director of the Innovation Center. Prior to this, I spent some time as a healthcare investor, including starting two healthcare service companies, both of which partnered with doctors in independent practice to support them in value-based contracting and in the additional investments in patients in terms of dietary supports, in terms of care navigation that they wanted to give to succeed in value-based contracts. I have a law degree, worked on policy in the first Trump administration, focusing on kidney care in particular, and started my career as a consultant. At the center, our mission is really about the topics we're talking about today. Affordability, about improving quality and lower costs, to put it in the statutory language. But for us, how we can unlock increased affordability in our healthcare system, not through higher subsidization, but through actually reduction in what the federal government's outlays are at the same time by increasing productivity. Much of our healthcare system is a labor-dependent equation where we take labor, we compete to retain it in the healthcare workforce as opposed to other parts of the economy that have increased productivity and therefore can pay more for that work over time. What it costs to produce a laptop today versus the year 2000, what a single software engineer could do today versus the year 2023, to put it in starker terms. How do we retain that person so that they are a nurse in a hospital? How do we retain that person so they go through residency and practice medicine? We have to pay to help people maintain socioeconomic status or stay close to it in order to maintain the best and brightest in the workforce caring for patients. And that puts upward pressure on the cost of care because your staffing ratios in the hospitals don't look too different. And the dialysis center, the nurse to patient and the technician to patient ratio are actually not that different today versus 10 years ago. And so, in order to maintain that, what we want to do is unlock productivity in other areas. And
So, Abe,
I,
before you go on, I just want to make sure we nail this point. You're saying that you want to focus on unlocking affordability and that productivity, increasing productivity, is the main primary means of achieving that, correct?
that's correct.
Got it. Thank you.
And it's basically described Bammels cost disease, but um, we have the opportunity to unlock productivity. The classic way, and you mentioned the drug space, but the classic way that we have that occur in the healthcare system is that people invest in drugs, bring pharmaceuticals to market. At a certain point, they go generic, and then the cost of getting an outcome has decreased once that occurs. And even in the time before it goes generic, oftentimes the cost of getting an outcome relative to hospitalization for a long time, or not actually being able to achieve the outcome at all in the absence of the drug, is achieved. You mentioned AI. That is another form of productivity unlock. So we have models that are focused on paying for an outcome for technology, not paying for an activity in technology, importantly, and I'm sure we'll touch on that in this conversation, Cliff. But in essence, we have a new form of productivity to pay for in the healthcare system. And if we leverage both these things together, a thoughtful approach on drugs, a thoughtful approach on technology, what we're able to set up is increased access for people at more affordable prices and also more affordability for the taxpayer and the federal government itself. And so looking at our model portfolio of what we've constructed in the last year, four of the nine models we put out connected to drugs, two connected to leveraging technology in new ways, and you have two-thirds of the portfolio dedicated to this. And from the other third, I'd really highlight our lead model as a incentive for the healthcare system itself to adopt some of these new ways of enhancing productivity, locking in your revenue line as a system or a practice for a decade while being able to have flexibility in how you leverage different tools without rebasing in that time period to lead to you to have a counter pressure against the adoption. And that's very different from the financial incentives that a physician or a hospital face in the absence of a guaranteed structure like that, where really the application of some of these promising technologies is revenue cycle management, is administrative optimization of processes, but not clinical delivery, because clinical delivery, if it's not connected to a payment structure, is not something that you're incentivized to do, absent a sustainable value-based care arrangement. So even our core structure of what the center has done for the last 15 years has taken on new meaning as the way you unlock value in our structure, I think, has radically shifted from a, for many players, optimization of coding, which is, the RCM of value-based care, to an optimization of how you actually engage and reach people using different tools, using different staffing mechanism, which is what I think marrying the new structure of a 10-year baseline with new technologies has enabled.
A notable shift. Indeed. Thank you. Yeah.
And so that's how I think about our model portfolio today. I think it stays grounded in the same statutory mission. We are continuing the vast majority of all the models that were kicked off. We have more in the Medicaid space to try and incentivize this than before, largely through commendable efforts on the part of my predecessor to shape those. And I think we have the right portfolio to meet this moment and drive some change.
So, Abe, then the three sort of buckets of models are several for drugs, a few for technologies, and the others for incentive structures, correct?
Yes.
So it's kind of a three-pronged approach there. And then this shift, can you just hit on that shift one more time? I want to make sure we don't lose that point. Shift from what to what?
So if we think about the classic accountable care model or value-based competition model, a lot of that has in the past been about optimization on factors that are largely inherent in the model itself and not things we wanted done. And so there are different forms that this has taken. Um, in the reach model, to call out, the current model, we have allowed for the combination of the TIN with the NPI, so the tax ID number, the provider ID, and there's a lot of work that's gone in on the part of ACOs in actual construction of the ACO to ensure that you are maximizing how we'll approach payment. If we restrict it to a TIN approach, there's less reward from that. Part of the reason why this was necessary was our benchmark construction methodology worked a lot better for some groups versus others. Whether you have a history of coding on the population, if you're a historically high cost ACO, you were kind of shut out. And so our new approach in lead has something designed for both extremes. For the folks who have a ton of experience in risk, we're going to basically plus you up with what we're calling a wedge, which essentially recognizes that in the absence of being in a risk arrangement, your spend would have been higher, and therefore the benchmark for comparison is higher. The hamster wheel is not going to keep accelerating. Whereas for the folks who have less experience with risk, we are going to say that we actually should look at basically where your costs have been historically and say that's where you are and spend that down over time. If we just took an approach of say, let's blend your costs with the region, there are some people we overpay and some we underpay. And so doing that, but then doing these adjustments that I described gets us to approximately the right position to be in for both sides of this equation. So that is about benchmark construction and construction of who you put in the ACO. There's also how you document on the population and capturing that, which can drive enhanced revenue, similar to a pattern we see in Medicare Advantage, of course. That is the world as it existed. Now, people did this and then also invested in clinical care and also made new resources available. And that's wonderful and that's great. And that's how we've seen good quality results in many of our models. But moving to a world where you cannot optimize in that way and there's less of a need to, And so it really becomes about better care delivery and using new tools that the fee-for-service structure does not incentivize adoption of is the world that we're trying to get to.
So this is cool. So with what in lead, with what you're calling wedge, you are revisiting benchmark construction in a way that in part doesn't penalize for you doing the right thing. It provides incentives to keep going, right? So that's the benchmark thing might sound sort of technical and dry, but actually it's about enhancing incentives, correct?
That's right. And sorry, I got too jargony there is the
Oh,
call out I
no,
think I just got.
we got it. But we want to make sure we understood the jargon so we can take it home with ourselves. Thank you. So that's about lead. That's great, Abe. Are there any other models you want to call out in particular, at least at a high level?
Um, Maybe one, I'd love to call out the access model, which I'm going to call out our Chief AI and Technology Officer, Jacob Schiff, and then also two clinicians on our team. Well, one who recently departed, Dr. Will Gordon, who was our Chief Informatics Officer and recently left, and Dr. Susanna Bernheim, who's our CMO. Um, Susanna, Will, and Jacob really teamed up in a thoughtful approach for how we should pay for technology when it is outside of the approach used by the traditional care delivery system and what it means to measure meaningful outcomes for that population. And so we have four tracks in the access model. And access is really at its heart about digital therapeutics. But we didn't micromanage and say this standard, this approach on tech. What we said is an open-ended approach where we pay for an outcome. And so we have a track on early cardio, kidney, metabolic health. We have a track on more advanced cardio, kidney, metabolic health. We have a track on MSK, and then we also have a fourth track on behavioral health. And within each of these tracks, we define qualifying criteria, and then we define an approach to say, here are the four metrics that we are measuring you on. Here are the five metrics we're measuring you on. And what we want you to do is measure the baseline of the patient coming in with engagement, and then a year later, measure where they're at. And we will pay you is a monthly payment for having the patient engaged. Plus, at the end of that year, if you've driven the improvement, what we will also do is give you the amount we paid out over the year again for driving the improvement. But way we structured that is we said it's about driving improvement with half of the population you're engaged with. So if you do not do that, you do not get the payment. If you drive improvement with at least half the population engaged with you in the track, then you get the entire payment of that extra 50%. And what this structure does, it looks at real outcomes that we set up a way to measure, and we say, okay, A1C levels, let's look and see where you are for the patient relative to where they are. Next year, have you driven improvement? And then in future years, we pay for maintenance. And so what this sets up is a way that a health tech company that previously would have gone direct to consumer in the cash pay market, or maybe an employer would have purchased as a benefit and says, there's actually a real market for you now to go and engage a Medicare beneficiary and help them manage a condition, help them stay healthy, help them improve a bit, and then maintain that improved level. And we have a win for you because it will translate into large savings and reduce utilization for the healthcare system. This is something that will help people stay healthy. And what we are going to do is structure a way that you win financially for doing that, not with something that is a new technology add-on payment commensurate to the value you drive. Frankly, we're paying less than the value driven by these interventions for the system. But what we're doing is setting up a way that technology could be applied in the healthcare system in a deflationary manner.
Aha. So with cardio, kidney, metabolic, you're picking up, that's a lot of people in the Medicare program for sure. So that's it's a big take, a big ask. And then MSK, was that musculoskeletal or? Okay.
Yes.
Um, and notably, I think I heard you say you're going to pay, you're getting the baseline right again, which is key. You pay for improvement and maintenance. Did I hear you correctly on that?
For most tracks, we have maintenances in future years.
Yeah. Hmm.
Uh, Not the MSK track, but the other tracks.
You do. Okay. Great. Um, I wonder, Abe, there are a couple of things we want to kind of get you to talk about a little bit. Maybe you want to get into drug pricing and maybe MFN at this point? Would you want to jump into that, or do you want to go into evidence-based care and kind of how you draw on evidence and so forth.
Why don't we go to drug pricing
Let's do it.
and
Since you already
MFN?
did
Happy
mention
to go there.
drugs, you mentioned drugs, and the cost to get outcomes is decreasing, which is an important financial point. And so that was a good way to bring that up. So let's go to drugs.
Great. I guess I opened the door to it.
You did.
Um, would a maybe just an overview of our models, or is
Yeah.
there a broader place you're hoping to start, Cliff?
Well, the models certainly, and how we move into drug pricing, if you care to venture there, and if you care to venture perhaps in the most favored nation stuff, not so sure if you need to go that far, but if you care to do so, that we'd like to hear about it.
Yeah. So it's important that we have drugs available to the American people. It's important both that we have drugs available to the American people today and in the future. And so having an incentive for investment in the pharmaceutical space makes sense. Um, if you're a biotech investor, you're someone in this universe, and you're underwriting a potential investment, you typically today are looking for somewhere between 60 and 70% of your profit to be derived from the US market. We are not 60 to 70% of GDP today in this country, if we look at what the United States represents. In the wake of World War II, it was a very logical approach to say the US can incentivize this development because we're in a position to value this more than most societies. We have seen a rise in wealth in other parts of the world. The US still outstrips many developed parts of the world in wealth, um, but we are not the same share of GDP that we once were. And so, if we are going to have a sustainable incentive for development of new drugs over time, such that our grandchildren live longer than we did, have longer health spans than we enjoy today, um, we do need to encourage pharmacological innovation to continue. We need to encourage lifestyle change, and that's something we spend a lot of time on the center, but it's also important that there be continued investment. And one lesson I think we can draw from the passage of the IRA and political rhetoric in this space is that the current equation is not sustainable. By not acting, what we are doing is endangering pharmaceutical innovation. And so, if we could act today to make drugs more affordable for the American people, we will set up a sustainable equilibrium as opposed to our status quo, which has proven itself unstable. And doing that in a thoughtful way that does not just land on the US government taking a broader class of drugs and saying, let's negotiate directly and, in essence, deliver price cuts there, but instead setting up equation where we tie what we pay to a basket of other developed countries and use our ability to shape the incentives that pharmaceutical companies face to give them a credible threat to walk away from the negotiating table with another country. What we will do over time as this plays out is maximize pharmaceutical revenue in the set of countries that we have selected for our basket while lowering what we pay. And so the idea of most favored nation, or of taking an international pricing index and tying what we pay to some average of that, is one that conceptually makes a lot of sense and I think is the answer for how we make drugs more affordable today while sustaining the incentive to encourage further development. And we've taken this concept and applied it in three domains. One, we've introduced the generous model, which is a voluntary model through which manufacturers can offer MFN pricing from a basket of drugs,
You
sorry, basket
started
of
the generous.
countries,
I want to make sure we heard you. The generous.
generous.
Okay.
And you'll see all of these models that I talk about in the MFN space start with the letter G. We tried to make it easy to remember. So these are the G models. I take a lot of pride in the naming conventions of how we approach things in the Innovation Center. My team makes a lot of fun of me. But I do remember that Generous, Guard, and Globe are three drug models in the MFN space go together. So Generous is about states getting an alternative to their current rebate structure if the MFN price is lower than the state's price. And manufacturers have voluntarily come in to join that model. Globe is a model that we have proposed, but not yet finalized, that would be a mandatory Part B model that operates in 25% of the country to impose the MFN price on Part B drug sales in place of the ASP plus 6 approach for those drugs in those parts of the country. Finally, GUARD is the approach to take MFN pricing and import it into Part D in 25% of the country for plans in those parts of the country. And so Globe has the B for Part B, GUARD has a D for Part D. GUARD is also finalized, but is proposed but not yet finalized. What I'd say is there's actually, as much as it's a similar concept, differences in each of these models. Generous accrues the benefit of state Medicaid programs, putting additional resources into states' budgets and the Medicaid program to support our most vulnerable. Globe directly translates into lower drug prices for patients who are beneficiaries of the Medicare program through Part B. Finally, GUARD translates into more stability for the Part D program. In Part D, we do have a maximum out of pocket on the what a patient pays. It's $2,000 index for inflation and what was set up in the IRA. And so the problem in GUARD was not the patient costs, but there is a point on cost spreading throughout the year because the mechanism for smoothing that costs over the year that the IRA set up has not played out in the way that many people expected it to. But the core problem there is really the premium increase and the instability of the Part D market. And so GUARD has a different equation of what it's solving for. Those are really the three MFN models. But I want to go beyond that because there are two other existing models to highlight. One is a model focused on making GLP-1s accessible to a broad array of Americans, where I'll call out Dr. Vin Midha, who really was the conceptual thought leader at the Innovation Center behind a lot of our approach. Vin and the team that he led did a ton of work in taking a balanced approach. The model is called Balance to incorporating lifestyle interventions with access where clinically appropriate to GLP-1s. Both Lilly and Novo have come into the model, and we are now making it available both to states for Medicaid as well as to Medicare plans for Medicare Part D coverage of GLP-1s for obesity and a slew of other conditions as well. And so that model is a way that we can expand access to truly promising innovations to a broader array of Americans. We got price concessions as part of this coverage expansion using the center's authority, and I think is really a novel use of our authority. I also want to highlight a model that was in the portfolio at the time that I came in to the center, and that is our cell and gene therapy model, which currently focuses on sickle cell disease. And I call this out because it's a model that there had been a really thoughtful set of incentives in place to bring manufacturers to the table that the Biden administration did a very effective job at setting up. And then when we came in, we recruited 33 states to come in and actually opt in to this model. The model is about Medicaid beneficiaries with sickle cell disease having access to promising cell and gene therapies. And there were two from different manufacturers that had opted in. And we offered that pricing with an outcome aligned payments and got states to opt in for it to say we're in a pool, uniform prior auth regimen, uniform coverage standard, no negotiations across these different states. And through that, we've gotten to the point where 86% of Medicaid beneficiaries with sickle cell disease are covered by the scope of the cell and gene therapy model. Building on that experience, this past weekend, I, along with some members of my team, published a piece in the New England Journal of Medicine laying out our vision for how we should approach cell and gene therapies more broadly, laying out the factors that led to success in the sickle cell approach for that model, and how we might approach a multi-indication version of the cell and gene therapy model. We have not proposed any changes to the model at this time, but we have laid out our thinking publicly on that because we see a very, very promising pipeline in the FDA right now, and we need to have clear answers on how we're going to approach reimbursement here in a way that is a win all around in order to encourage further investment in this space and ease market access for beneficiaries. And
This
so
is a really big deal. So just want to add to this, Abe, and I just happened to come upon the New England Journal article just by chance. I said, we're talking to that guy in a few days. Um, this is a tough going after in cell and gene therapy, including for sickle cell, is no trivial matter. I mean, one great thing is that you're this is directed to helping a large group of people who've been traditionally underserved and ignored. Sickle cell's nothing new, and we haven't had very good treatments for it for the longest time. Cell and gene, the gene therapy for it is a big potential jump. And glad that you're hitting on it for 33 states, and that I think you said 86% of those folks can be covered. One thing we're noticing about cell and gene therapy, which is another kind of hurdle for you, it seems like the production mechanism for the sickle cell gene therapy is kind of a bottleneck at this point. And I imagine you're seeing that. I know we haven't discussed this, but do you see that as a kind of a hindrance to achieving your goal here? It's a tough one.
So we are seeing that. Um, Ultimately, our tool is directly on the payment mechanism.
Right.
Now, we could, of course, incentivize payment in different ways by giving higher payments in earlier years, factors like that, which would give a disproportionate incentive um, to getting the production facilities set up and running. Um, I think one thing we can do is make it easier for manufacturers to be able to predict the timing of when coverage would begin post FDA approval. So then they're able to do some of that planning. I don't think it's a problem in how much we pay or the way we pay, but rather about the ability to predict when that payment will come online that is causing this. I'm also open to hearing what you're observing on this, Cliff, because
Yeah.
we want to learn and get this right.
Well, point well taken. If you can provide some measure of decreasing uncertainty in the horizon for the manufacturers, they're more likely to pursue kind of a more efficient production process, and they're still kind of ramping up on how to do that. But it just, I for one welcome hearing that you're going after CGT, cell and gene therapy, that you're going after sickle cell. It's long been neglected, and so kind of kudos to the program, and I hope you keep leaning on that. Back to the GLP-1s that you mentioned. Good gosh, how do you manage payment, Abe, uh, for a set of drugs whose indications continue to expand, which brings in more populations, and everything going on internationally with regard to patents running out and generic forms appearing and prices going down and down in various countries? It seems like it's kind of a messy thing to get your arms around.
Um, at its core, we are evaluated based off whether our models improve quality and lower cost and cannot regress on either metric. And so the question that we confronted, um, it was my front office team, so the deputy is Susanna, I mentioned, and actually the person who had served as chief strategy officer under my predecessor and stayed on for a few weeks to help me orient. So we were all sitting around, and I'm like, all right, we're going to run at GLP-1s. And they're like,
You're
that's outside
brave.
the bounds of our authority because, how will you save money? So here's the theory of the case that the actuary did accept and sees a credible path and how we're going to save money here. Um, we, by statute, cover the diabetes population with GLP-1 access. That is something that is just covered in bread and butter Medicare. By statute, we do not cover weight loss. Part of this is when uh, when the drug program was being authorized, right? So we're going back to 2003, um, Medicare Modernization Act. Uh, Obesity was not viewed at the time as a chronic condition. It was viewed more as a choice. I think we've seen some societal evolution as we've gotten more tools for addressing this and helping people manage their health to say, actually, if we could address obesity, it would have downstream beneficial health impacts, and that this is something that we should help manage. Um, and so, with that shift in mindset, we have not seen a shift in the statute. And so the statute says you cannot cover this. What is interesting then is to go to the manufacturers, which is what we did, and say, you cannot be paid for Medicare for doing this. We will not do that. We see that as outside the bounds of the law. We would like to be able to finance expansion of coverage here. Um, in order to finance that, we need you to drop your price. And we need you to drop your price not only for the population that you would gain expanded access to, but also for the diabetes population.
Oh,
And one key factor, similar to the sickle cell situation, of there being two manufacturers with approved products, is that we're in separate rooms having those conversations with each. And so what you saw play out was a negotiating technique to say, we will give you this massive expanded market and extended in exchange for a price concession. And if one manufacturer does this, the other one is going to lose a ton of market share. And
yeah.
so there was a dynamic where both Lilly and Novo, I think, felt some degree of pressure to cut a deal and come in and give us a reasonable price. Um, and I had a price point that the actuary accepted, where if the diabetes population was covered at this low of a price, given the uptake assumption the actuary made of how many people would be diabetic versus how many would be newly covered obese, um, um, and the balance there, we had to get below a certain price. Um, and so the idea was negotiating with the manufacturers to get below that price and playing the dynamic that the other one might go there to get concessions. Now, we made other concessions in it in terms of the coverage approach, of how robust we'll cover it, in terms of the fact that the manufacturers get to offer the lifestyle intervention. At one point, we contemplated that being a third party aspect. But the core point for us to be able to finance this expansion and have it score as a saver in our actuarial evaluation was driving down price points sufficiently that the existing covered lives with diabetes would cost less, and that would be sufficiently less to finance the expansion to those who benefit from the new coverage over weight loss indication.
Great counterbalance there, if I'm hearing you right, because not only you're not taking away from the people with diabetes, you're increasing the efficiency of their care. You continue to care for them, expand as necessary at a lower price, um, and then you're enabling perhaps some broader coverage elsewhere. So this is great inside baseball on how you kind of did negotiation here, and it sounds like you've kind of probably burned a lot of midnight oil with your actuaries on this one too.
And I'll give credit, there was some room in the joints because the actuary did assume there would be some benefit, of course, to the GLP-1 uptake. And so there was room in that this did revenue maximize as well for the manufacturers, but the weight did not need to be carried significantly by that because of
Right.
this price concession dynamic.
So this is kind of very good kind of model for value-based pricing, where value gets you better care at a lower price. And you're still keeping the manufacturers in the loop because you're negotiating with them, right? If
We are. This is a voluntary model. There was
Yeah.
no requirement to come in. And I
Wow.
think the manufacturers each see this, given the equilibrium where they did not come in, as something that they really had to take on and do.
And they're willing to play ball with you then, right, Abe? It sounds like they're coming to the table, eh?
There were agreements reached with both Novo and Lilly, that is public, and we are currently recruiting health plans into the model. We do have a structure where we need to have 80% of covered lives in Part D in for us to avoid a risk selection against plans. So we put in a threshold where the model does not take effect for a given year unless we clear that threshold, and we are actively soliciting plan applications now to opt in to benefit from this dynamic.
So to sit back, this is great. You mentioned the IRA before, and the IRA had those provisions for Medicare price negotiation, which at the time was very controversial, and that kind of got rolling. But it sounds like you've built up and around that in different dimensions to improve value. Is that correct? I mean, you're kind of doing a whole variety of things built on top or around price negotiation.
I mean, my critique would be that I think the IRA both conceptually was flawed and has had unintended consequences.
Mhm.
I think we've seen some instability in the pricing of the Part D market due to the IRA. In essence, we've seen a reversal of some of the structure of how rebates enabled lower premiums for folks. And I think it's concerning. I also think conceptually, we just paid a cost of the government stepping in to negotiate here in how folks will underwrite investments here. And so I would not have voted for this approach, and I think there are flaws. That
Mhm.
said, the IRA is the law of the land, and there is not a downside to negotiating as hard as possible under all authorities because the cost has been paid in terms of how people underwrite things. And so the posture of the administration correctly has been um, we will negotiate and we will negotiate hard on drug prices. And so I think you've seen that in how we approach this as opposed to
Yeah.
the first year of negotiations under their program. That was intentional of just like we're negotiating the scope of in the GLP-1 space, our team, and I was not part of it, did negotiate in a relatively tough manner with the manufacturers. This was not a coddle them situation. All that being said, we take the structure of the law of the land how Congress gives it to us. And our job in the Innovation Center is to test out different ways to approach payment, to do Y instead of X. And so what you've seen us do here in the GLP-1 approach, in the approach on the most favored nation models, is look to do modifications on the existing framework. A lot of our most favored nation approach for Medicare in Globe and Guard are really modifications on things set up in the IRA. Generous is different than that, just given the IRA did not have the same implications in the Medicaid market. And balance is different than that in that it's a voluntary model where we're not doing modifications there. We're doing modifications on coverage instead. Um, but that's been intentional. And I think you can expect to see more activity from the center in the drug space. Um, I have more than if we look at our hiring plan, I have more than doubled the size of the team that works on drugs and drug pricing in the
Mm.
Innovation Center. Um, it is an increasing focus for us because it's a area where I think there's a large opportunity to both lower costs of what we pay today and incentivize further development in key strategic areas.
So this has been encouraging and eye-opening to me, I must say. So you've covered MFN, and you had your three Gs there with Generous, Globe, and Guard. You led us into some inside baseball on the GLP-1s and its role there. And again, it's such a complex, evolving field. Kudos to you if you can keep your arms around that. And then the cell and gene therapy stuff, that could make a very big difference for a lot of people who have been underserved in the past. It's going to maybe capitalize on the latest that we're doing with genomics and so forth, and all the CRISPR stuff, and gosh knows what else. So you seem to be moving the ball forward on those. They've got to say. Um, can I get your brain to switch over now to AI? You kind of gave us a little bite of it earlier when you talked about productivity and how AI could help fuel productivity, but at least at a high level, can you give us some insights about what you're thinking at the center?
AI is a really promising tool. Um, one of the flaws I think of how we've encountered tools in the past in healthcare is that in healthcare, we pay off of a fee schedule. And so there's not necessarily a clean incentive to adopt a tool. If you become more efficient, do the RVUs go down? That could be a bad thing if you're optimizing off of, what people think of when they hear the word productivity. To poke a bit of fun at myself here. The approach where we say we should have a new technology add-on payment for AI, or AI belongs on the fee schedule to increase adoption, is problematic because the AI does not have a natural limit on its use. It's not a tool that you need a human in the loop on the use of. You don't need hours from anyone's day going towards it. It could be infinite utilization as long as you can engage patients with it. Um, and I think that would be a problem because it would lead to an explosion in what we spend on healthcare. It would expand access, but it would become quite expensive. If we could set up a structure where we say we care about an outcome, we care about people having better health, we want to deliver health efficiently, expand lifespan, expand health span, and I don't care what exact technical approach you take, but I will pay you for doing that. I think we could incentivize investment because venture capital funds will do VC style returns if they could get something that does not have a human in the loop, so it scales infinitely. They don't need a massive amount of money per patient to engage with the patient and keep them healthy because they will serve millions of people at a, scalable way, right? Like you talk about different fields. Someone who becomes an author, high variability in return of what you get, but the people who have the best sellers do well, go on the speaking circuit, right? There's the movie and theme park that you could get, if you're really successful. Whereas in medicine, you tend to be bound by, oh, I can only operate on one person at a time. I can't operate on anyone. I'm not a doctor, but there are people who could do that. Um, Breaking that link to say, all right, let's help you care for your panel of patients in a maximally efficient way, such that you could cover more patients and you could reach them, and there's not a wait list to see you because your patients are supported by an app that you've helped them sign up with that feeds data back to you and alerts, oh, actually, we need to get Mrs. Smith in to see me, and helps me prioritize to see Mrs. Smith for an appointment. That would be powerful. It would help address a lot of the shortage we have in our healthcare system, where it's hard just because there's 6 months until you get in to see that specialist, or even getting into PCP might take 2 months for a new patient. It's not your time. There's always space for emergencies, of course, but too often the answer in their system has been, why don't you go to the emergency department? Because I can't get you in. And I'd love to change that answer. I'd like to make it easier to get in the true emergencies because fewer of the routine stuff truly need the attention of the clinician. Um, right? Nurses take a ton of training. Nurse practitioners have go through a 2 year program. Doctors go through medical school plus residency or fellowship on the other end. If we could alleviate some of this pent up demand that cannot be met with our current workforce, such that our workforce could spend their time engaging people who really need them, that will expand access in our system. That will make care more affordable. And so we've tried to set up an approach where we will pay for use of digital therapeutics that deliver good outcomes. And we are setting up structures that the healthcare system adopt things through the accountable design models and ACOs. We are also setting up things like the access model that have outcome aligned payments for use of tech. And we're thinking through other use cases where we should pay explicitly for engaging folks in a different way.
So with regard, Abe, to digital therapeutics, as you said, are there any statutory or regulatory hurdles to achieving that? I'm just reminded what you said earlier about diabetes and then obesity, not being able to pay for obesity. With digital therapeutics, is anything kind of in the way in statute for being able to pay for that or reimburse for it?
So with access, we have done a test to reimburse for it with this outcome aligned payment.
Mm,
Um, And so we've literally enabled the technology companies to enroll as Part B providers, and we'll pay them. And so we're using our authority to test this out. And so the one of the positive things in the Innovation Center's domain is that we get to experiment with things that modify parts of the statute and see if they work. And if they do work, improve quality, lower cost, then we could run them as perpetual models. It does not change the language of what Congress passed, but it changes in the real world application the effect to say there is now coverage for this thing that otherwise there would not be coverage for, and it is anchored on delivering a positive outcome.
a very important point about the models. If you can call them perpetual, if you can sort of have them continue and propagate, you don't have to run into the statute, but you can still improve access and increase value, correct? As long as the thing's still working, right?
That's right.
And if it does work, maybe someday it can be put into statute or Congress could maybe even act on it. We'll see. Um,
That's exactly right. And there have been cases of Congress taking ideas from models. Some of the best evidence for health at home came from an early innovation center grant done through a model called the Healthcare Innovation Awards. There is definitely a case of even when a model is not certified, we have learnings that Congress picks up. Um, you know, um, the insulin pricing model that it was picked up and used in the IRA and turned into law. So there are examples of this.
Great, thanks. Abe, we got about 5 minutes to the top of the hour, and I wanted, if you don't mind, to kind of let you sort of look ahead, blue sky if you want, with regard to where you see the program going, long-term viability of the Medicare program. or anything else you want to leave with our viewers here. What else do we need to know about where CMMI is going next? And maybe insofar as it's preserving the long-term viability of Medicare.
So, our focus is on making care more affordable, Medicare and Medicaid. We're trying to do models not as a let's change the incentive for this particular narrow slice to make it better. That's important to do, but what we're trying to do is do models that really get at making the healthcare system look different a decade from now. If we succeed with LEAD, suddenly there is a perpetual model in which hospitals had a big incentive to adopt technology. To exceed in access, suddenly there is coverage for a new class of digital therapeutics. It's not about taking up a narrow slice. It's like taking up the things that we truly see making a difference in the system and trying to move the needle um, in a larger way. There are still gaps in what we've done, and I think what needs to be done for the system. Um, so we did 9 models last year. I will call out that we did not address fully the space with the Medicaid pediatric space, where we do not really have a thoughtful approach from the center trying to push forward accountability there. We probably should engage there. I'll call out that there's more to do on the drug space. We obviously spoke today, Cliff, with a good chunk of our time on cell and gene therapies and the incentives there, and our team's been thinking through that. But there are other areas in the drug space where we've been thinking through why there's a lack of incentive to have sufficient investment and how we could change that equation so people back up more there. There's more in the technology space. We have a model ending in the kidney care space where I think it's important that there be a path forward for how that will look like. So there's more to come as we look to try and fill gaps in our system. And I guess if I could sneak in an ask, Cliff, my ask would be to, as people have ideas of here is where you should engage, here's where you need to focus, this will move the needle in a big way. Please don't be shy, reach out and share them with us. Um, we're looking for things that impact the system at scale, but all ideas are welcome because we might end up packaging things together in different ways, and we're really just looking for dialogue.
Well, thanks, Abe. Well, everybody, Abe left the door open for ideas. And judging on what we just heard from Abe, he takes on new ideas pretty well and advances them. It sounds, Abe, that with lead and access as models and a few of your other models, you're looking to those to kind of take you into the future. You're proposing these new approaches. We're going to see how they work. They may be tweaked along the way, but those are the kinds of things that are going to get us there. Uh, Furthermore, as I'm looking across the kind of the notes that you left us, we're pleased to see that you've got multiple directions on trying to different ways of improving value care. You're addressing different patient populations. I'm thinking about diabetes, obesity. You're thinking more about pediatrics these days. There are a lot of rare conditions that would fall under CJT. The MFN stuff with the Globe, Guard, and Generous are 3 ways, including the states with Generous, of kind of backing them up for drug spending. The GLP-1 issue covers a lot. So you've put a lot on your plate, and we're very grateful, Abe Sutton, that you shared this with us. This has been a wonderful 50 or so minutes with you. And like we said, thank you for leaving the door open. You seem quite genuine about that and about taking in input. And we look forward to working with you more in the future. And if you got anything to final say, any final word of wisdom from you, Abe, before we let you go.
I don't know if it counts as wisdom, but I will say we are hiring at the Innovation Center. So if you have research assistants who might want to see government from the inside and are ready for that stint, please send their resumes our way. We are actively looking for people to help on model design, operational running of models, the evaluation team that helps look at model impact and how they're performing. There is a whole slew of things, and there is no better way to learn about the healthcare system broadly, have access to the data from tons of different organizations, all the ideas people are generating, then coming in and doing a tour of duty at the center. So that is the final note I will close on. Come and join us. We welcome and value your expertise. And Cliff, thank you so much for for this conversation. It's been a pleasure to get to join this group today.
Agreed here. Could have done better with a better guy, Abe. Thank you very much. We appreciate having you on. We really appreciate your time and your openness. You shared a lot. Take care, Abe Sutton. Thank you very much.